in the house. Shout out to NYC. All right, y'all. So let's go on ahead and get started. I have on this first slide that if you haven't had the chance to as yet to use this QR code to download the session PDF that we'll be using. So basically this PDF is something that is an interview template that I made. I have used it since I was a medical student, and to this day still use it in residency. It has been incredibly helpful for me in being able to diagnose and treat patients. A couple of ground rules, guys, feel free to make sure that you're muted on your mics. There will be Q&A at the end, so then we can kind of just like chill, relax, sit back. I'll stop the recordings then, and you can feel free to ask questions. And if you'd like, I mean, for now, it's actually totally fine to not have your cameras on because I can't see you anyway because of the way Blue Jeans is set up. But then when we're doing the Q&A, it would be great to be able to see you guys' faces so I can know who it is that I'm talking to. So here we go. We're kind of just jump right into this. So I want to start off with just letting you guys know, I hope that you are here for the session called How to Earn Clinical Honors on Your Psychiatry Rotation. And I want to just emphasize, so I'm going to focus on the clinical aspects of things. I think I can 100% say that where I kind of shone in medical school was the clinical side of things. I mean, I did fine with the exams, but you probably could honestly get better exam advice from somebody else. I am here to give you the advice on how to clinically excel on your psychiatry rotation. So an important disclaimer that I'm going to just share with you all. So I want to let you know a reminder, this webinar, it's to educate and to inform you guys on the best practices to provide optimal patient-centric care. So even though, I frame this in the way of thinking about you guys getting honors, because, as students, I know that that's important. At the end of the day, by providing patient-centric care, that is the best way to line yourself up in any rotation to achieve clinical honors. All of that being said, have to put in some legalese here. This has nothing to do with my residency training program. This is all me, just kind of wanted to do this. I really love education, helping folks. So this is just kind of me doing this on my own, wanting to be able to connect with the folks who are interested in psychiatry or who just want to be able to do well in psychiatry. And then the last thing, obviously, I'm not liable for your grades at the end of the day. I'm glad that you are here to participate in this, and my goal is to help you to achieve honors. But if that's not something that happens, I'm sorry, and we can talk. You can hit me up, DM me, whatever, email me to see what you can do to improve for the next rotations that you have coming up. So let's kind of hop into who am I. In case you don't follow me on social media, you have no clue who I am, you just kind of signed up for this session. My name is Dr. Atasha Jordan. I also have an MBA. I am a resident, I'm a second year resident actually here in Philadelphia. And as I mentioned before, I was born in Barbados. I lived in Barbados for a little bit, about 8 years, and then we moved up to the US. I went to Harvard for undergrad, studied neurobiology there, and then I went to UPenn for both med school and for my MBA, so I went to Wharton as well. So one of the things I really enjoy, so I have 10 plus years of experience in teaching and tutoring. So I've literally taught at all grade levels from kindergarten, preschool level up to the college level. I have taught, and it's something I enjoy. I have a lot of experience in it. I love doing it. You might not be able to tell, like I look a lot old, or I look younger than I actually am. So sometimes that kind of throws people off as well. But it's something I've been doing for quite a while. And I'm also a blogger. So one of the things that I use my platform for is to help to kind of just give my tips and tricks to other med students or to the med students coming up behind me about how it was that I experienced medical school and some of the things I learned, and hopefully you guys can kind of learn from my experiences. So a little bit about my journey, super quick before we kind of hop into the meat and potatoes of this. Obviously, everyone's always super excited about the white coat ceremony. I saw we had some pre-meds in the house as well, so that's super exciting. You guys are like getting way ahead of the process of being able to do well in medical school. But you start out, you're super excited, a white coat ceremony, you're like, yo, I made it to this thing that I've wanted to do for so long. Pre-clinicals, you're finding your friends. For me, I was a part of the Student National Medical Association. If anyone here is part of SNMA, throw some out in the chat, say a put a hands up, whatever it is. SNMA was a huge part of my experience in medical school, and I was actually the co-president of our local chapter at Penn, and it's something that is probably one of the most memorable parts of my medical school experience. Clerkship year, obviously, that's kind of what this rotation is all about. I don't know about you guys, and you can let me know this in the chat too. Honestly, clerkship year was probably one of the hardest, if not the hardest year of my life. I think combining the grueling nature of being constantly evaluated in medical school, plus, life keeps going in med school. So med school is hard, and then stuff is happening in your personal life behind the scenes. So I had kind of a mix of that and really had a hard time actually kind of navigating how grueling it was in a lot of ways, but clearly made it through. Interestingly enough, though, I did not do my psychiatry rotation during clerkship year. I actually took a month off from school then because there was some stuff going on with family. So I did not do my psychiatry rotation. I honestly actually hated clerkship here so much that I went to business school with the plan of not doing residency at all. I went to business school at Wharton, was planning to go into consulting. I did a consulting internship, and then I was like, this is not any better than medical school. So let's go on ahead and see if there's anything else in medicine that could work for me. Thankfully, in my 4th year of med school, that's when I eventually did my psychiatry rotation, because the administrators were like, girl, if you're trying to graduate, you need to finish this rotation. So I was like, all right, we're gonna do psychiatry. Lo and behold, I had no interest in it beforehand, didn't think I was gonna be a psychiatrist, but ended up falling in love with it. I worked at the Veterans Hospital in Philadelphia, had a beautiful time with the veterans while there, and realized that psych was actually something that I am really gifted in. And if you follow me on my blog or social media, you also know my faith is incredibly important to me. And I also felt that God had actually called me to work in the field of psychiatry. And as hard as residency is, I actually still feel that to this day. I feel very called and blessed to be able to do the work that I'm doing in psychiatry. And then the day that you're all looking forward to of eventually being able to graduate, graduation is definitely one of those like highlights of my life. First person in my family to become a physician. And for me, it was really beautiful to have my family there. My grandmother came up from the Caribbean to be there. She was like front row. It was great. So wanted to give a little bit of that backstory so that it's just not a random person talking to you about psych, but instead you kind of know a little bit about my story and why it is that this matters to me so much. So some of the things that we're going to talk about, honestly, I wanted to keep this simple. I didn't want this to be a super long session because, as you can imagine, right, like I can't tell you every single thing about all of psychiatry in just like a quick 30-40 minute session. But I wanted to hit on the high yield things that will really help you to stand out when it comes to being on your clerkship rotations and what will help you to be differentiated from your peers. So some of the things we'll talk about, what to expect, how to interview, and then the tea, we'll leave the tea for the end because it's piping hot. We want to let it cool down a little bit. And that's just really how to stand out and get honors. So first off, what to expect on a psychiatry rotation. My first day when I was on inpatient psych, that's literally the day that I kind of just fell in love. I worked specifically on the inpatient units. So just as a really brief and general overview for those who have never experienced this before, most inpatient psychiatry units are locked units compared to other parts of the hospital. They're locked for patient safety. They're also locked for staff safety. And these are locked units where patients, often their belongings are held in separate holding areas. There's limited access to even like phones and things like that on the unit. The units are designed also to be safe to prevent any chances or minimize chances of patients performing any self-injurious behaviors on the units. So a lot of times, especially as a med student, if you've never experienced it, inpatient psychiatry can honestly be kind of scary because it's so different than what you've experienced. But inpatient isn't the only type of clinical setting that exists. So depending on your medical school, you might do your psychiatry rotation in any of these types of environments. So whether that's inpatient that I just described, outpatient, which is basically following up appointments that patients are coming in, they're following up for chronic treatment of their mental illness, whereas on the inpatient unit, that's where you're seeing more of like someone who's coming in crisis. And that's something I actually really like a lot, where you see someone coming in crisis, whether it's with depression or with psychosis or mania. And the goal of the inpatient hospitalization is to really help the patient to kind of be stabilized in that moment, so that the hospital stays end up being about 7 days or so, kind of depending on which hospital you're at, what the reason is the patient came into the hospital. And that's really the difference between inpatient and outpatient. Outpatient is that chronic care, inpatient is the more acute care. You also have the crisis center or emergency department setting. So it really is either you'll be in an actual medical emergency department where there's a subsection for psychiatry, or as exists here in Philadelphia, we have separate crisis centers. So the crisis center is a space that's just for mental health emergencies, and we are able to then work in those settings to help get someone into inpatient care if needed. Typo there, that should say consult liaison. So consults, just as in any other consult service that you may be on, you're really thinking about this idea of how can you, as a psychiatrist or the person with psychiatric expertise, help, whether that be a surgical team or a medical team, with a patient who has either new or chronic psychiatric symptoms. And then another really common clinical setting that you might find yourself in for a psychiatry rotation is community mental health. So that looks different depending, again, where you're at, but sometimes that can look like homeless outreach, or it can be community mental health from the perspective of doing home visits if you're on a targeted care team or a case management team, to really go into people's homes and to really be the boots on the ground, helping folks to handle their mental illness. So overviewing where you could find yourself if and when you end up doing your psychiatry rotation. So the sub-internship, right? So we know that that's the next level. So clerkship year, that's kind of where you're expected to be a learner who is contributing, but first and foremost, a learner. The sub-internship, now it's where this is kind of like the real interview. So you're going in thinking about, how can I really present myself as someone who is ready to be a psychiatry intern in just a few months. And you really want to think of the things that you can do to shine, to show your knowledge, to show your clinical acumen, and really think of that as an interview more than anything else, which honestly kind of adds to the stress that already exists in medical school. But that's how it works. That's how it is right now. And if you want to get good letters, if you want to get that honors score on your transcript, you have to go into it that way and perform every day that you're there. But one of the things I will say is, if you really think of this more so from the perspective of, how can I really help my patients, and how can I do the best to give the best care possible to each patient that I interact with, then honestly, that's just going to make the process that much easier to just get honors, if you're working from a mindset of, how can I give the best care as possible. So again, I touched on some of these. So some of the common psychiatric presentations that you'll see, especially if you're working in a more acute setting like the emergency department or working in the inpatient units. So you'll most likely see things that are acute, like depression with suicidal ideations or with a recent suicide attempt. You may see mania, psychosis. You may see substance use disorders, anxiety, and malingering. And just FYI, I just thought of this. Sorry, guys. I realized I can't actually see if you guys are like leaving questions in the chat right now. But I will make sure to check that when we're doing the Q&A at the end. But feel free to drop questions if you do have any. All right, so one of the most important parts, and I really just kind of want you guys to kind of sit back. If you have your the templates that I made, the PDF templates of the interviews for both new patients as well as the follow-up patient interviews, kind of take, if you want to annotate on there, whether you're doing that on your laptop, doing that on a piece of paper that you've printed out, I want to just kind of walk through what I have created. So this is the document, kind of like a big picture screen of the document that I made. And as I said, literally to this day. So I made this in, what year did I make this? I made this in 2018, something like that, when I did my clerkship rotation. Yeah, it was 2018. And then I've obviously like adapted it over time as I've learned more, as I've kind of adapted my interview style. I've changed this form, but it's more or less the same template that I've been using since I was in med school up until now as a resident. And I will say, like, I've always gotten really good feedback on how I interview my patients, how I present my patients. And a lot of it is because I believe in being systematic. This paper right here, I literally printed out front and back on one piece of paper every time I go into an encounter, whether I am in the emergency department, whether I am on an inpatient unit, whether I'm doing consults. This piece of paper allows me to make sure that I'm being thorough, and it helps me to make sure that I'm organized so that when I'm interviewing a patient and then presenting the patient, I don't miss key information, and I'm also going in an order that attendings are used to hearing and that will allow you to communicate effectively. So one last chance, in case you missed the QR code before, in case you missed all my emails that said to download the template, here's your last chance with a QR code to download the template so that you can kind of follow along with me in looking at the document as a whole rather than in the pieces I'm going to kind of break it up into now. So let's start off with kind of just the general history, right? So in a lot of ways, a psych interview is honestly not that different than a typical medicine interview. You still have the same key components where you're thinking about the history of the present illness. So you're thinking about the problems that a patient's coming to the hospital with, and how is it then that you will help them in the future by understanding what has been going on in the past. And you'll also want to make sure to get a review of systems. So I don't know what mnemonic you guys use to collect a HPI. I have always used the old carts one. I don't usually write it down here, but I'll kind of just go through it if I can even remember it off the top of my head. But for HPI, old carts. So I use old is for when did the symptoms start, onset. L is the location, which doesn't really apply so much to psych, but more so of like what type of symptoms is the person having. D for duration, C for characteristics, A for aggravating factors, R for relieving factors, and then cards, T for time course, S for severity. So I still do that stuff, and I think now that I've just been in practice, like I don't have to go through old carts, but that's just the information that I want to make sure I have collected in the HPI for each of the symptoms that someone is complaining with. So if someone comes in with depression and anxiety, then I'll do old carts for depression first, then anxiety. So what I have here now and before I skip this, so patient goals for admission. That to me, I think that is in and of itself right there. Like if you collected that as a med student, that already puts you above your peers, because that is showing that you are centering what matters to the patient in your treatment plan. Because I had a patient once, and this was like a few months ago, she came into the hospital depressed. And I think typically our first thought is patient presents depressed, put them on an antidepressant. But because I always make sure to ask my patients, like, what is the goal that you have from being here in the hospital? She said she wanted to feel better, but she also said she did not want to be started on medications. So I would not be providing her proper care if I just try to shove antidepressants down her throat. Instead, what we did was we walked through a plan of how she could be started with a psychotherapy program outpatient. We talked about coping mechanisms that she could develop on her own to help her to feel better. We talked about alternative treatments, so whether that be things like exercise, yoga, acupuncture, other types of remedies that she was more likely to actually do on a regular basis instead of taking antidepressants, which you didn't want to do. So if you as a medical student were to actually ask your patient, what goals do you have for this admission? Or what is it that you want us to do for you? Or what are the symptoms that you want us to target most? What's bothering you most? If you focus your interview on that, if you focus your care on that, you will 100% stand out from other medical students, because it's honestly not really that commonly taught, but it's so important to making sure that you're aligning with your patient for what matters to them, because ultimately we're just a conduit of being able to provide the care that our patients ultimately will engage in. So after that, then you once you get the story, I kind of like to kind of fill in the blanks of other symptoms that were not mentioned by the patient. And honestly, as a medical student, I would say I did kind of do this checklisty, because when you're learning, you kind of just want to make sure you don't miss stuff. But I'll give you a tip and trick if you're ambitious and you want to kind of try something a little bit more advanced. When you're collecting the review of systems, a really good way sometimes to collect information is to ask someone to tell you what a typical day is like for them. So with that, I'll ask someone, hey, like, what time do you wake up in the morning? Do you have breakfast? Do you go to work? Like, I'll have them walk me through all of the aspects of their day. And by the time we have done that exercise, I've learned about their mood, if they're sleeping, if they're eating, if they're doing the things that they care about, what's their energy level like? Are they taking naps? And I can gather that information without having to say, how is your mood? How is your sleep? How are you losing interest? Do you feel guilty? Because that doesn't really flow so much as like a conversation in the interview, which is what I aim for. So as I said, starting out, the checklist is fine because that is also how I started. But over time, like let's say you're at the sub-I level, if you're an MS4 who's in this session and you're trying to like, do that interview, right? Like you're doing that interview to get a good letter of recommendation for residency. That's a good task or a good technique to try. So the way I have these listed, and I'm not going to go into like a ton of detail because that's more content based and today is more of like a structural kind of day. But the first column of these symptoms are, I hope you guys kind of guess it, these are the SIGI caps related to a screen for depression. The middle one is a screen for, well, actually, let me ask y'all, I'm going to jump out of this so I can actually see what's going on here. What do you think that middle column, those symptoms are screening for? You guys can leave it in the chat. Yep, exactly. Yep, mania, exactly. So that's what that middle one is for. And just as a reminder, if anyone has their mic on, if you could turn it off, that would be great. So the middle column is the screen for mania, because you always, in any patient, you want to do a quick screen for depression, quick screen for mania. And then, so let's see, the first three items of the right-sided column, what is that screening for?
Schizo.
Yep, exactly. So, and I think we'll even so what I like is some people have said schizophrenia, Madison has said psychosis, and I want to phrase it as psychosis, right? Because remember, when we're collecting information, we're not actually making a diagnosis as yet. We're collecting information that will give us information about signs and symptoms. So for instance, like that middle column is for mania, but mania, if someone has mania and psychosis, those are going to be two very different diagnoses. So just being careful that you're not necessarily screening for a disease as much as you're screening for particular symptomatology. And then the rest in that column, however many there are, the rest in that column are associated with what types of disorders? Thank you, Trish, for sharing that. I wasn't sure who it was. But do you guys have a sense of the remainder of the items in the right column? They all are a similar type of diagnoses together. Nope. All right, no worries. I'll give you the hint. So these are all actually commonly associated with anxiety in a lot of ways. So PTSD in many ways is thought of as an extreme anxiety disorder. Stressors can lead to anxiety, can also lead to depression and mania. Trauma and abuse often can relate to anxiety as well. OCD is an anxiety spectrum disorder, ADHD, that one less so. But these are all things that we want to screen for when we're seeing patients, asking about history of these things, also asking about symptoms that someone would experience if they were to have either of these types of presentations. So now that we kind of have a sense of the initial presenting symptoms and the presenting situation, now it's time to kind of get into some history. So again, my goal is always to try to make this as conversational as possible, but sometimes you just have to ask the questions. So when it comes to past psych history, this is a section that's going to be quite different than your typical medical interview, right? Because typically, honestly, medicine doesn't really care that much about the psych history, whereas a psychiatrist, that's one of the main things we care about. So some of the things to think about, we have onset of symptoms. I always ask, like, is this the first time you're depressed? Have you been depressed before? What diagnoses do you have that you're aware of? Have you been on meds? Have they been helpful? Have you been compliant? Like, all of that information is incredibly helpful. Have you previously been hospitalized for a psychiatric reason before? Do you have outpatient care, case manager? Really, really important. You always want to ask every patient, even if they did not come in with depression or suicidality, have they ever had a suicide attempt, or have they done self-injurious behaviors like cutting or burning? Always want to screen for safety in any of our patients. So some of the other things, so we'll also do a substance use treatment history. So again, in psych compared to medicine, we'll go into even more detail. So some of the things that matter for us, especially for alcohol and for benzos, is thinking about withdrawal history that has been complicated by things like seizures or by like delirium tremens, for instance, because those are things that can be life-threatening withdrawals. But then also, things like when did they start? How much do they use? When was the last time they used? Overdose history. These are all things that are incredibly helpful from a psych perspective, especially because we have a lot of, let me rephrase that. There are treatment options for some of these substance use disorders that we can offer medical treatment for. So kind of getting a sense of the severity of someone's illness kind of helps us direct which treatment path might be best for a patient. And then going into more history, so kind of your typical past medical history. Are they seeing a primary care doctor, other healers, allergies? Family history, we kind of tend to target and really specify mental illnesses in the family. So asking like specifically, do you have history of bipolar, depression, schizophrenia, substance use disorders? Do any of those exist in your family? And then if anyone has had treatment before, what have they used? Has it been helpful? Sometimes that can just be good information to have, because if someone says like, hey, my mother was taking Lexapro, for instance, then they might have a greater affinity towards being able to feel comfortable starting onto antidepressant. And sometimes, I actually don't know off the top of my head the studies about this, but I think sometimes they've seen that what works in a family member might actually also have increased efficacy for a relative. So that's one of the reasons we ask about which medications a family member might have taken. Social and developmental, again, this is a section that we tend to go into more depth compared to a medical, definitely more so than a surgeon, when it comes to getting our information about patients. And I'm actually on a child psychiatry consult service right now. And I thought, like, as adult psych, we got a lot of information. Like, on the child side, we're asking, what grade are you in? Do you have pets? What is your pet's name? Like, we are getting to know everything about these children. So here it shows you childhood education, social support. And this is actually a really, really, really important part of the history, because a lot of outcomes in mental health illnesses are related, in fact, to social factors. So when we're thinking about the education that a person has, or childhood traumas, or social supports, income, all of these things impact the ways in which someone is able to get access to and maintain access to care, or even their willingness to get care to begin with. So if we're not getting information about this, you are not fully treating your patient. And one of the things as a med student, again, because you guys tend to have more time, like let's say you're limited in the initial encounter that you can't get all the information you want, you have time to go back and make sure that you're filling in the history that's important. Military history is important because the vets have tons of really great access to mental health care. And we always try to get vets to really lead into utilizing that care, because they have such great access compared to a lot of the private providers or even public providers that are outside of the military. Spirituality. So if you follow me on social media, you know that spirituality and mental health is something that is really important to me. And what I found in my research is that even though in medicine, people in medicine tend to be much less religious or spiritual than the general population, because actually most of our patients are spiritual or religious, this I have found, I have started to integrate this in the past few months to check spirituality for my patients. And I would say so far, I'm at about 60% of the time, patients want to interact with a chaplain, or they share that their spirituality is a really important part of their lives, which is important for us to know when we're thinking about healing and like the cultural nuances that we're providing for care. The remainder of here, so I have pertinent labs. So in psychiatry, we do get labs. Contrary to popular belief, there are a lot of labs that are really important for psych. So make sure that you are paying attention to those labs when you are kind of seeing patients. I'll throw out just a couple quick examples. So for an initial psychosis eval, for instance, if this is a patient with new onset psychosis, you might want to make sure the patient has a TSH, so a thyroid level, B12, RPR. These are looking for other causes of psychosis other than psychiatric illness, because there are organic or medical causes of psychosis that do exist. The mental status exam, so that is thinking about, basically, this is the physical exam of psychiatry, will you say. And I won't go into the details because honestly, that could be a whole hour lecture on its own. But I'm hoping, and you guys can let me know in the chat if you would be interested in me going into more detail in different sections in future sessions. But here, basically, I want you to at least know the names of the different parts of our exam. Coming out of an interview for psychiatry, you want to be able to create a visual picture of what this patient is like, and that is what the mental status exam aims to do. Last but not least, so this is definitely something I am actually planning to do a separate session on. So I don't know, let me know in the chat if you have ever heard of the biopsychosocial spiritual formulation. All right, cool. Thanks, Kristen, for letting me know that you're interested. And for other folks, have you guys heard of the biopsychosocial spiritual formulation? No, okay. All right, cool. So truthfully speaking, this is not something that is, well, first off, I learned from one of my good friends who is also in psych, and she's in psych, or she's a med student going into psych, and she's in California. Even her med school hadn't talked about the biopsychosocial spiritual formulation. So it's one of those things that's not always taught, but I have found it to be an incredibly important way to conceptualize a patient. Meaning, when we think about the biological, the psychological, social, and spiritual aspects of a patient's humanness, of all of the things that are related to who this person is and why they have presented to you in whichever clinical setting, when you think of all of those different components together, it allows you to create an assessment that is much more targeted from a diagnostic perspective as well as a treatment plan perspective. So as I said, again, similarly to the mental status exam, the biopsychosocial spiritual formulation is something that and it is when I'm working with med students on the units, I do a whole hour-long lecture on the biopsychosocial spiritual formulation because it's helpful in psych, but truthfully speaking, it is incredibly helpful regardless of what specialty you go into, because a lot of times, even in general medicine, if you're not paying attention to the social needs of your patient, you're not going to appropriately treat them because you might be providing a prescription for a medication that their insurance doesn't cover, or they don't have enough money to pay the copay for what it is that you are prescribing. So if you're not thinking about all those factors, you are not doing your diligence as a care provider. And my goal is to make sure y'all are doing your diligence as future physicians. And the other thing is, so for anyone here who has a sub-I coming up, I would say, so plans and assessments and plans, I would say for clerkship students, try your best. That's basically it. That's all that is expected of you. If you try an assessment, so you do your one-liner, your differential diagnosis, what you think treatment should be, you've done enough. That's good for clerkship year. For the sub-intern, so someone who is now really doing that month-long interview to get into psychiatry, you're going to want to go a little step beyond that. You're going to want to be able to say, kind of put your money down on a specific diagnosis. Which diagnosis do you think it is? Which medication do you want to prescribe? At what dose? Do you plan to titrate at any point? You want to make sure that you are running the show for your patients. And we'll kind of get into some more of those pearls a little later on. And then what I'll talk about next, so that was all for a new patient encounter, meaning that this is a patient you're seeing for the very first time, and I'll go back. You have seen this person for the very first time. You don't know anything about them. You need to get all of that information. So this template is for the follow-up evaluations, and this is also included in that same document that I suggested that you guys downloaded. So when you're following up, especially on the inpatient unit, and I think most medical students end up working on the inpatient unit, which is why I'm kind of tailoring it that way. But you want to just kind of check in. And again, the goal is to try to be as conversational as possible. So how are you feeling, and like ask probing questions. So like, let's say I ask my patient, hey, John, how are you feeling today? He says, all right. I'm not going to just go be like, okay, cool. How are the meds? No, I'm going to probe that. I'm going to push that, because our role as people and providers in the psychiatric realm is that we want to get to understand why, like multiple levels of why. So if John tells me I'm all right, I'm like, oh, all right. Is that better or worse than yesterday? Maybe John says better. Oh, great. Like, what about that feels better to you, John? So it's all about probing questions. It's not just the surface level question. It's almost the surface level answer is almost never the answer you actually care about. You want to get like a few levels beyond that when you're asking questions. Also, so if you like started any medications, stopped medications, ask about how they're doing, if they're having side effects. You should probably know in advance what the side effects are of the medications that you're starting, so that you can know what to ask your patient about if they're having the side effects. And then here for symptoms, I kind of just threw in some of the common symptoms you'll want to review. We don't have to go over the details of that. And again, every single day, you're going to do another mental status exam and update your assessment and plan. So here we go. We're kind of getting towards the end of like the things I want to share. And I actually did not create slides for this because I want y'all to pay attention. I want y'all to take notes, write some stuff down. I just kind of put them on my own sticky notes, and I will just share some of the pearls that I have used and I have learned over the years and have shared with my mentees. Several of my mentees last year, they did phenomenally on their sub-internships. They like matched at their top programs for psych this year, and I'm like super excited. And honestly, like my goal literally is to help y'all just like be great, whether it's in psychiatry or not. So hope you have your pens and paper ready. So I'm going to share some of the things that you specifically can do as a medical student, whether you are in a clerkship or if you're in a sub-internship, to stand out, because you're like, I think of it from the perspective of what do I want my medical students to do that makes my life easier, makes the attending's life easier, makes the patient care better. And that's what all this is going to be about. So see patients. How about that? I have had medical students who literally were like, no, I'm good. I don't want to see no patients. You're not getting honors with that kind of attitude. Like, you really can't. And you probably know some of these people in your class who are like, I am here so I don't get fined. You're not getting honors if you're here so you don't get fined. All right, so see some patients. That's step one. And when you see your patients, make sure that you are thinking ahead to what it is that you actually want that encounter to be. So you are going to have more valuable encounters with your patients if you think ahead, what are the goals of this situation? So let's say, for instance, an example where we have a patient coming in with depression, and because you are a med student who wants to get honors, in your initial interview, you ask the patient what their goals are, right? So that patient with depression said, I want to be able to get sleep. That's what they said their goal is. Maybe you might have some additional goals that you'll offer the patient as well, but the patient told you they want sleep. So when you go into your encounter, you have a few things in mind. You want to check in, is your patient sleeping? Because you're addressing the goals that the patient stated, but then you're checking in on their mood. Are they feeling any better, worse, or the same as they had felt the day before? You want to see, you started some medications. How are they feeling on the meds? Always go in with a goal of why you're talking to the patient, and that'll help your encounter to be that much more fruitful. So that's tip number one. The next one that I have, kind of, this is relating to the function throughout the day. So these are things that really you can help to just make the flow of the day easier for everyone on the team. If you are allowed to write notes for patients and they count in the chart, I know nowadays they're not allowing med students always to write notes, and your notes sometimes don't count. But if they do, write the notes. I mean, you're going to have to do them anyway intern year, like literally intern year, your job is to write notes. That's write notes and put in some orders. So the more you get practice on doing them and doing them efficiently yet thoroughly, then you'll be able to kind of just even be a more effective intern going forward. So write as many notes as you can. That'll really help your resident, because your resident is out here running about doing all the things. If you can help them out with like 2 notes a day, trust me, like when I had my med students writing a couple of notes, I was like, thank you, because now I don't have to write 10 notes. I only got to write 8. So that's super helpful for the team. And the more helpful you are, that's the more memorable you will be and the more likely you will be to get honors. So other than writing notes, I think there's some other things that are really helpful that honestly, I think a lot of people don't think of, and that's where you really get to stand out. So getting really strong family collateral. So in psych, our collateral is so important because let's say someone comes in with psychosis, the nature of what psychosis means is that the person has a disturbance from reality and that they're not with it fully. So their history obviously is important, but you're going to want to get history from people who know this person well. And not only do you want to get the history, if you are allowed to document it, put it in the charts. When I tell you, like my med students who take good collateral and I like see all of their collateral in the chart of what is this patient's baseline, what are they usually like before they were sick, do they usually take their medications if this is a chronic illness, what are the patient's goals at home, how much do they engage with family at home? Like when I see a med student who has put that in the chart, I'm like, yes, thank you, because everyone now has the ability to know this information about the patient. You have centered the patient in this care and allowed them to be able to get the best care possible. Another thing that's really helpful, safety plans. So you might not have heard of this before if you haven't done psych yet, but something that is really important in psychiatry is safety planning. So the short version of that is basically you talk about what are behaviors or moods that trigger a person to do things that are unsafe. You ask them about things that they can cope, that help them to cope, people who help them to cope, places that help them to cope, and care providers. And typically you can just like Google safety plan and you'll find templates online of safety plans that you can use. So most of the time, well, I'll say this at least for the hospital that I work at, we have to be able to do a safety plan for any patient who's being discharged. So, and especially if they came in with suicidality, we want to make sure that the patient has a plan, that they know what are things they can do to be safe, to try to minimize the chances of returning to the hospital or returning or having a potential suicide attempt in the future. So that's something else. The most recent med students I worked with who 100%, like, I literally was just like, can y'all just come with me on every single rotation? Like, literally, they were phenomenal. One of the things that they did that really stood out and was so helpful in driving patient-centric care was doing scales. So one of the things in psychiatry, because we don't have, like, you know how in diabetes, for instance, you can track someone's hemoglobin A1C over time to monitor their glucose levels. We don't have those types of screeners in psychiatry. What we do have are different scales. So for instance, there are mood disorder questionnaires, or there's like the Hamilton Anxiety Scale or the Hamilton Depression Scale, and different institutions use different scales. So I'd encourage you to check in. There's also scales to track mania. There's scales to track psychosis. And what it does is it allows you to quantify. So using symptoms that relate to specific numbers, quantify the degree of illness that someone has. So when you do those scales, and if you do that as a med student, like, when I tell you, it's so helpful, because like, let's say a patient comes in incredibly manic. On day one, let's say their scale on like the self-rated Altman scale is like a 20. You're like, all right, bet, like this person has mania. But then by the time you've given them some lithium, maybe you've started them on a 2nd generation antipsychotic as well. Okay, day 10, all of a sudden homie's at like a 2 and he no longer has this like symptom of mania going on. And what you can show is a quantitative way to measure that, rather than just being like, oh, patient's better. No, you can be like, he came in with a scale of 20, representative of insomnia, talkativeness, like you can tell that. And then you'll be like, well, today on day of discharge, his Altman self-rated scale is a 2, showing that he has a good response to lithium and to quetiapine. You feel me? So like, those are the ways that you can stand out. Like, you can be like the med student who said he's better, or the med student who says his Altman self-rated scale was this, now it's this. So again, the scales, really important way that you can stand out. And the last thing that I will really emphasize, well, actually two things. You know what? No, I'm looking at my Post-its. What else do I want to share? Oh, it is two more things. So the other one is having a plan. So I kind of mentioned this before, but the more specific you can be with your plan of what you want to do for the patient, even if you are wrong, especially as a clerkship student, it's okay to be wrong. Just say something. Like if you want to start someone on an antipsychotic, say you want to start an antipsychotic. If they say which one, just guess. If you don't have a specific reason as to which one you'll pick, just guess one. Say something that sounds smart. Even if you're wrong, you'll be like, you tried. That will give you more points than just being like, I don't know. Like, just say something. That'll be helpful. And the other thing I have for people who are going into the sub-Is, okay, this is an additional way to stand out. So in addition to regular notes or an H&P, discharge summaries and discharge instructions. If you're able to do that, like you basically want, right, like the person to say, this student is functioning at the level of a resident. To function at the level of a resident, that means you are writing discharge summaries, you are writing instructions, you are putting in orders, you are writing all of the notes, you're doing collateral, you're doing these scales, you are doing all the things. So the more of these things that you can do, the more you're going to perform at the level above, quote unquote, where you're supposed to be. And that's how you get honors. You perform above and beyond what is expected of you. So I hope that that kind of covers all of the things. And as I said, I want to make sure that I leave time for questions. So that's kind of like the meat and potatoes. I have a couple more things and then we'll get into questions. I want to offer ways for you guys to say thank you to me for this session. Honestly, as I said before, I mostly just do this because I want to. Like, I thought of it one day and I was like, hey, let me just have a session. I like teaching and I like the ability to kind of talk to more than one person at a time to like get information out to multiple people. But if you do want to thank, the ways to thank me, follow me on social media. That's one way. And honestly, I really just like communicating with people. There are some people I've met in real life off of social media, slide in the DM, say, hey, ask questions. I don't always respond right away, but I will always respond. Sometimes it might be like 3 weeks later, but I'll respond. It just kind of depends on how my rotations are going. I'm on Twitter as well. I'm on TikTok, trying to be like the youth and trying to be on TikTok. I'm on there showing a lot of videos related to Christian mental health. So you can feel free to check me out there. A lot of it is like educational videos with a couple of fun videos sprinkled in. You can also check out my blog if you would like to support. My blog is something I've been doing for quite some time. I started it when I started doing psychiatry, because that first day of my rotation I mentioned, I was just like, yo, there's something different about this and I need to be able to document it. So if you go to my blog and you kind of like go to like the oldest post and start there, you'll literally be able to see my journey of becoming a physician just kind of unfold over the course of me blogging. Venmo. I say this because with my blog, like I don't actually use my blog to make money, but like things cost money. So having a website, having an email address that's separate from my other ones, they all cost money. So like if you want to throw me like $1 on Venmo, throw me a $5 on Venmo. $5 would pay for like my email account that I pay for monthly. If you threw me like $10, that would help cover the cost of the domain. Whatever you think you would want to be able to share, I would greatly appreciate it. Not required by any means, but if the Lord leads you, like how they do with collection in church, go on ahead and send your girl $1 if you feel like you want to support me in any way. Another way that you can support, so I actually make this gear that I sell on Teespring, and if you check out my Instagram in particular, you'll see I wear these quite a bit. I mean, I love them, and they're great conversation starters about Christian mental health, which is actually where I'm planning to focus my career. So if you want to support, you can either use the QR code, or if you go to teespring.com, you can search Jesus Plus Therapy and you can find sweaters, t-shirts, mugs, those types of things on there. Learning resources for you guys. So as I said in the beginning, this is mostly for clinical stuff. Like I wanted to really give you guys the clinical meat and potatoes for psychiatry. I mean, I did fine, obviously, when it comes to my test because I'm here, but it's not really my strength to like give you like tips and tricks on like how to study. I love online med ed. I think the biggest thing is just knowing what works for you videos work for me. So I was a huge fan of online med ed. Obviously, you want to do some kind of question. My school was like pretty partial to UWorld. I think Amboss is another one that people use a lot, but I never used them. I just have only ever used UWorld. And honestly, I can't say, like, I don't know if one textbook is better than others. If you guys have been doing rotations already and you have found like a certain brand of textbook that you prefer, feel free to just kind of like shoot that into the chat if there's like a brand of textbook that you prefer when it comes to kind of just like working on studying for the for your like shelf exams and things like that. So the last thing I want to share, actually, and this is kind of like in some ways seems out of left field, but not really. I want to share this before we get into questions. So last year I discovered something called Ikigai, and it is a Japanese concept which I felt like perfectly really just describes how I feel about psychiatry. So Ikigai is this idea of finding something that you love, finding something you're good at, finding something you can be paid for, and finding something that the world needs. So there are ways to find each of those separately, but when you find them all together, that is your Ikigai, or your purpose in life. For me personally, I genuinely feel that psychiatry, and specifically teaching others about mental health and about Christian mental health in particular, is something that I love. It's something that I'm good at. It's something I can be paid for, not by y'all, unless you want to like bless a girl. But it's also something that the world needs. So for me, it honestly like makes me so happy to be able to work with my patients, to be able to share what I've learned with you guys. So hopefully you will all be really great psychiatrists in the future and find your own Ikigai in whatever it is that sets your heart on fire. So with that, I will open it up to questions. And as I said before, we can just like chat, real talk. I'll kind of just actually stop sharing my screen now. You guys, please feel free to turn on your cameras. Let's just chat for the next like 15 minutes or so. I'm going to stop recording too.